Pranav Patil. There? Yes, sir. A journey through suction loss and smile.
Posterior lenticule cut once completed 80% suction loss occurs. Traditionally, in this scenario, we would have opted for surface ablation or LASIK in the same sitting or at a later date. In this surgery, we decided to go ahead with SMILE at an anterior plane. In the initial surgery, the cap thickness was 120 microns with a diameter of 7.2 mm and the optical zone diameter of 6.2 mm. In the subsequent surgery, the cap thickness was 100 microns with a diameter of 7 mm and optical zone of 6 mm. The pupillary area was clear and hence centration and fixation was not a problem. Here we can see the anterior plane SMILE is being performed successfully. The surgeon starts by identifying the posterior plane. However, he does not see any meniscus sign. The surgeon comes out and goes into the incision eccentrically in hopes of identifying the anterior plane, and on joining both the planes finds out that he has been dissecting the anterior plane all along. The surgeon again attempts to identify the posterior plane and is successful in doing so, as seen by the meniscus sign. To dissect the plane, the surgeon enters centrally first, which makes him enter into the posterior lenticular plane inadvertently. He realizes this, comes out, and goes into the incision eccentrically where the anterior plane was dissected, and the SMILE surgery is uneventful and goes off smoothly. Even before the laser delivery starts, we can see a superior fluid meniscus which is increasing with every second. The posterior lenticule cut starts, and as it is about to complete, conjunctiva starts creeping in, suction loss occurs superiorly, the lenticule side cut is created successfully. The surgeon goes ahead with the procedure, the cap cut is being made, and at the end of the cap cut and the incision cut, the conjunctiva obstructs its delivery and we get a superior opaque bubble layer. On checking the treatment data, the SMILE incisions were created. The superior limits of the SMILE ablation and the incision creation were slightly hampered due to the conjunctiva creeping in superiorly, and hence it was a huge challenge to identify the incision site and the incision plane. The surgeon needed multiple attempts at finding the incision and opening it up. Once opened, we noticed that it was a very small keyhole incision which was less than 2 mm in size. We expected there to be an issue in plane identification. However, this was not the case. Anterior plane and posterior plane both were able to be identified easily, and the surgery went on successfully. Posterior lenticule cut is being made successfully. After this, the patient starts moving his eyes. The lenticule side cut is made eccentrically. The conjunctiva starts intruding inferiorly. The surgeon proceeds with the surgery. Inferiorly, due to the overhanging conjunctiva, the limits of ablation are not well defined and we get a massive opaque bubble layer. During dissection, gentle hands, patience and utmost care is important so as to avoid any retained lenticule and to avoid getting any buttonholes. Since there is a massive opaque bubble layer inferiorly and the limits of SMILE ablation are hidden under that, the dissection tends to be more difficult and we need to have a patient outlook towards it. Once the lenticule has been extracted, it is imperative to see it for intactness. Here we are trying to oppose the lenticule to the area where we thought that there was a retained lenticule bit. Using a slit beam, we are examining the area wherein we thought that there was a retained lenticule. A second pass is made at the dissection to make sure that there is no retained lenticule and all the fragments have been successfully removed. The interface is washed and the case is closed successfully.
Very nice. This is a Smile 500.
Yes, sir, VisuMax
Smile
500.
Pro, this does
No.
not occur, no?
So mostly because of Smile VisuMax 500, the suction time is longer, especially after the lenticule side cut is made. So mainly we find it in the cap cut that the patient starts to be uncooperative. So mainly that is an issue, but with the newer platforms like Silk and Smile Pro, this does not seem to be a big issue because the suction time is too less.
How frequent, how rare is this?
Okay, so there are two things. First is a surgeon's learning curve. So in the initial 1,000 cases across various publications and across various meta-analysis, they have found it to be around 5 cases in 1,000. But in the next 1,000 cases is hardly 1 or 2. So it's also a learning curve for the surgeon, and also how well and how crisp and clear your instructions are to the patient, because we have to deal with verbal anesthesia. Because
I
it
think
has
it's
been
important. Yeah.
it has been noted actually that they don't prefer to sedate patients who are undergoing refractive surgery, because they have noted that the oculocardiac reflex is more when the patient is sedated, which can be a trouble sometimes. So we prefer not to sedate the patient.
Yeah. Any questions? Any questions from the audience? I think it's important to, especially in Smile, to keep talking to the patient continuously. Focus, focus, be steady, be steady, be steady. Normally it takes about 40-50 seconds.
Yes, sir.
In a
Depending on
Smile.
the correction, anywhere from
In
around
a
18 to 40.
Smile Pro takes hardly about 8 and 10
10
seconds.
seconds.
Anyway, good.
Thank you, sir.